Thank you. I loved hearing Tony's comments there about essentially being smarter about clinical trials, and if I may just carry on from that a little bit. I mean, just look at the oncology world. Human patients are subtyped. You're HER2 positive, you're HER2 negative, you're this receptor positive, this receptor negative, and that absolutely defines whether an anti-cancer treatment's going to work. And it's no reason to think pain patients shouldn't be any different. So I loved listening to that. I'm going to move on now and talk about another system. In some respects, this is an old and tired system. Tired because we've all heard about it. It's the prostanoid pathway. And yes, we are going to revisit it. I'm going to be talking about EP4 receptor antagonists and give you some insight into what's been happening on the veterinary side and human side and where this might be going. So just to recap a little bit, the prostaglandin production pathway, we're all very familiar with phospholipids being converted to arachidonic acid, and then the action of cyclooxygenase enzymes to produce prostaglandins. And again, we're very familiar with the treatment effects, good and bad, of the cyclooxygenase inhibitors. But then each of these prostaglandins acts on their own receptors to produce effects. And so this is where it starts to get even more complicated. So PGE2 here acts on one of 4 different receptors, EP1, EP2, EP3, and EP4. And my presentation here is really going to be focused on the EP4 receptor antagonists. So essentially drugs that block the binding of prostaglandin E2 to the EP4 receptor. So these are prostaglandin receptor antagonists. Come under the umbrella of, they're non-steroidals, they are non-COX inhibiting non-steroidals. A little bit difficult to find if you do an internet search, but the World Health Organization did define these prostaglandin receptor antagonists as piprants. I think that was an attempt by someone to try and distinguish these from non-steroidals, but essentially they are non-steroidals, they're non-COX inhibiting non-steroidals. The next few slides, the information I've taken from this review from a few years ago by Woodward and others, really summarizing the different prostanoid receptors and what they may be involved with. And I think there is going to be quite a bit of information on the next 4 slides, but the underlying message is that these different receptors, EP1, EP2, EP3, and EP4, are involved in a lot of different processes. If you look at EP1, pretty much ubiquitous location throughout the body. Physiological responses, absolutely involved in pain, possibly more so visceral pain. Certainly a role in homeostatic functions in the gastrointestinal tract, some role in the kidney, immune system, and cancer. This is going to be a recurring theme across the EP receptors. In terms of potential therapeutic role that you would sort of tease out from all the early basic science, possibly a role for blocking the EP1 receptor in cystitis, cancer, and maybe hypertension. Moving on to the EP2 receptor, apparently the least abundant of all of these receptors throughout the body, but on neurons, GI tract, kidney, and other tissues. Very similar roles, and this is where there is a lot of redundancy in these systems. So certainly plays a role in pain, as well as gastrointestinal function, renal function. We see reproduction coming in here, back to the immune system, and then again cancer and a role in angiogenesis. At the moment, as far as I'm aware, there are no EP2 receptor antagonists in development for any particular indication, which probably suggests that amongst all those functions, none of them really stand out and have led to a therapeutic role. For EP3, again, we're now back to fairly widespread location throughout the body. Very similar, kidney, gastrointestinal tract, nerves, In terms of physiological responses, again, pain, a role in pain of the EP3, a role in gastrointestinal homeostasis, kidney, immune system, cancer. Again, we're just reiterating what we've seen with the other receptors. But in terms of potential therapeutic roles, pain, rheumatoid arthritis, some allergic conditions, and cystitis, as well as cancer. So on to EP4. Pain, I guess if you take a high-level look at all the basic scientific data, pain comes out higher for the EP4 receptor. And so evidence to indicate a role in joint inflammation, hyperalgesia, and various allodinic and hypersensitive states. But other physiological functions in the gastrointestinal tract, modulating mucus and bicarbonate production, and again, bicarbonate production, mucus production in other areas of the gastrointestinal tract. Does have a role in renal function, some vascular and lung effects, bone effects, immune system, and then cancer. And this is probably, again, for the EP4 receptor, it's the effect on cancer progression, cancer metastasis that really starts to stand out. So those 4 slides were just to give an overview of the different EP receptors, where they are, what systems they're involved with. But let's start to focus on the EP4 receptor. And so this publication is a nice kind of segue into that. And they use various rodent models of primary and prolonged allodynia and showed that PGE2 stimulates the synthesis and anterograde axonal trafficking to increase EP4 availability at axonal terminals, producing a prolonged nociceptor sensitization. And this may feed into some of the work that was presented earlier on today. And these researchers go on to say that blocking the COX-2 prostaglandin E2 EP4 receptor signaling at an earlier stage may prevent the transition from acute to chronic. And so the idea here is that prostaglandin E2 is increasing EP4 availability and therefore producing long-term sensitization of the receptors. But it's not all positive. So here's some work by Sujita and others using acute and chronic inflammatory pain models. And this is where you see in the literature, they're starting to look at EP4 receptor antagonists. And so compound 1 in these models had no effect. No analgesic, no anti-hyperalgesic effect. Prostaglandin I2 antagonist had no effect either. But in combination, these two, the EP4 receptor antagonist and the prostaglandin I2 receptor antagonist, did have a positive effect. And I think this wasn't an unreasonable finding because there is so much redundancy and we're really down to blocking individual receptors here. And with so much redundancy, you might expect to start to lose efficacy as you block an individual receptor. These data showing maybe a relative lack of utility of the EP4 receptor antagonist are balanced by data like these. And this particular compound here show fairly potent analgesic and anti-hyperalgesic effects across a variety of different rodent models. And it's this compound that has gone into human clinical trials and also is now approved in veterinary medicine under the drug name Grapiprant, trade name Galaprant. Just before I move on to that and discussing relative efficacy and then ending up with where the human clinical trials are, I just want to show you, so we're talking about pain today. I was asked to talk about the EP4 receptor antagonist, so I thought, well, I should do my due diligence and go on to clinicaltrials.gov and see how many trials for pain are ongoing. So this is what I did yesterday. Went on to clinicaltrials.gov, search term, very simple, EP4, and I came up with, I think there's 20 hits there, all for cancer, except for one. So at the moment, the registered clinical trials with EP4 receptor antagonists, the only trial related to pain is this one for headache, which tells you probably that there's certainly a lot of excitement about the EP4 receptor antagonist as anti-cancer, adjunctive anti-cancer agents. However, that shouldn't necessarily lead us to say, well, there isn't potential for the treatment of pain. I think one overlay, and I'd be interested in other people's perspective on this, one overlay that we might be missing is that I gather, or at least I've heard in conversations, that since that the Merck issue with Vioxx and maybe not disclosing some of the adverse event data, and subsequent events, particularly finding that non-steroidals are associated with an increased risk of cardiac events in people, have led the FDA to really raise the bar on the data that need to be put in front of them in terms of safety for any drugs interacting on this pathway. And I've heard that may be leading pharmaceutical companies to shy away from seeking approvals for drugs acting on this pathway, because now the process of producing data is so much more burdensome. So, whether that's playing a role in the lack of EP4 receptor antagonist pain trials, or whether other factors, I'm not sure. But I will circle back to that at the end. So let's go back to this compound and just a little bit of history here. It started off in Pfizer, then one little group was spun off, and a company in Japan called Requalia was formed. They held on to this compound and then licensed it out to Askei Inc. in Japan. I believe it's that company that then ran the human phase 2 trials in osteoarthritis. Since then, this company have out-licensed it to a Chinese company who now have pain trials for an undisclosed pain condition and cancer trials. So on the human side, this molecule has life. On the veterinary side, Aratana Therapeutics purchased the rights from Requalia. They took it to development and approval for canine osteoarthritis pain, and Aratana were then snapped up by Elanco, so Elanco now own Grapipant. I hope that's all clear. I cannot find any published data regarding the human clinical trials on this molecule, but documents I've been privy to indicate that it had an equivalent effect on OA pain as non-steroidals and fewer side effects. And I'll circle back to that in a moment. But maybe, going back to our theme of naturally occurring disease models, if you're on the human side here, you can think of this as a model. If on the veterinary side, these are the patients that we're trying to treat. And this is a study looking at Grapipant for osteoarthritis pain in dogs, run by Aratana. And this trial design was to test the effectiveness of Grapipant. You can see the dose there over a 28-day period, classic kind of treatment time period in these sorts of trials. It was a masked, randomized, placebo-controlled, multi-center study, 285 dogs. And you can see the split there, just over 140 dogs in each group. There's a placebo group and a treatment group. I should say, I should have had a disclosure slide at the start. For full disclosure, I was involved in consulting on some of the very early data regarding this molecule many years ago, and then helping in the design of this trial. And I've also been involved in some consulting for Eli Lilly that I'll come to at the end. Sorry to forget that. In terms of the outcome measures, these were owner assessments. So this was the primary outcome measure, were owner assessments under these blinded placebo-controlled conditions. And this canine brief pain inventory that I showed this morning, these data were then converted to success failure. Now, the FDA CVM, Center for Veterinary Medicine, has moved from saying, let's look at group values and means, to to saying each individual patient has to be converted to either a success or a failure. And you can be a failure and still have improved, but until you reach the bar defined as success, you are a failure. So it really dichotomizes the data, and it's led to people trying to figure out how do you define a success, and it's really pushed the numbers needed up in some studies. So this next chart I'm going to show you is success failure for the primary outcome measure, which is the canine brief pain inventory, modeled on the brief pain inventory for people. And you can see here, treatment success on the y-axis. Here we have placebo, here we have grapiprant. So placebo success in this trial, just over 30%. The grapiprant success, just under 50%, or just over 48% there. If you're not used to looking at success failure, that doesn't look great, does it? I'm only, as a clinician, you look at that and you think, well, only half my patients are going to be successes. But remember, this is a very artificial, in many respects, artificial cutting of the data, because it doesn't mean that only 48% improved. So success failure was defined along these measures here. These are components of the brief pain inventory, and as indicated, or as developed by Dottie Brown, who developed the brief pain inventory, she proposed these improvements in the different sections, domains of the canine brief pain inventory as indicating success. So that's how it is. So I think, this is a new molecule, a new way of looking at the data. The first thing you probably want to do is to say, well, how does it compare to our current treatments? And so comparing apples to apples, we can look at carprofen. Okay, and so you're actually looking at a pretty similar outcome for carprofen. Carprofen, for those of you who are not familiar with it, is a non-steroidal anti-inflammatory drug. It's a COX-inhibiting non-steroidal anti-inflammatory drug, maybe somewhat COX-2 selective a little bit, or preferential rather. But you're pretty much in the same ballpark here in terms of success failure. I think, the one thing that's a little bit interesting to me is that the delta here, 23, 33, 43, 45, 22 roughly, 22. The delta here is a little bit bigger than 31, 41. You see that? So the way the groups are differentiated is maybe a little bigger with non-steroidal. But I think you're still in the same ballpark. And there is absolutely no doubt about it. Grapiprant is effective for pain associated with osteoarthritis in dogs. And you can see here, these are now the actual pain severity scores and pain interference scores. The pain severity scores are questions about the amount of pain. The owner is asked, how much pain do you think the pet is in? The pain interference scores are where the owner is asked, how is pain interfering with your dog's ability to run, walk, do these other activities? And Dottie Brown considers them separate domains. And so you can see here a reduction here. This is the mean percent change. A more negative value is better. You can see the solid black circles of the grapiprant against the placebo. Remember, this is day 7, and so they both started up here at this point. So this will be the starting point at day 0, and then you start to see the drop down. And the differentiation here between treatment and placebo, this is much more what we're used to looking at in terms of group means to show the efficacy of an analgesic. It's been great to hear the discussion about numbers needed to treat and effect sizes. And if you look at numbers needed to treat, now what you have to remember is that number needed to treat is very dependent on group sizes and slight changes in data. And so when you've got one study and a relatively small study, you have to consider that might be a somewhat unstable number. That said, what I've done here is to take the publicly available data for grapiprant, for 2 non-steroidals approved for use in dogs. So this is deracoxib, a selective COX-2 inhibitor, carprofen, a maybe somewhat preferential COX-2 inhibitor, and celecoxib, the human COX-2 inhibitor. And I've just plotted here the numbers needed to treat taken from these bits of data and publications. And you can see here that you're looking at, I calculated for grapiprant about 5.5, daracoxib just under 5, carprofen just over 6. Celecoxib, this is where you get variation. This is after 14 days of celecoxib. This is after 91 days of celecoxib. And so you can see the variation there. But I guess, standing back from that graph, you would say, well, maybe the numbers needed to treat for grapiprant are really, they're in the same ballpark, the same area as the other non-steroidals. We can also look at effect size. So numbers needed to treat is based on success failure. Effect size is based on group means, deltas, standard deviations. And this is effect size compared to placebo. That's important. And so I've calculated for grapiprant. I've gone to the human literature and taken from Zhang et al. An average for non-steroidals, and then Baneroo's study on celecoxib here. And pretty much where you'd expect it to be. The effect size for non-steroidals is 0.3, give or take. And so the grapiprant is in that effect size range. So I think, it clearly demonstrated efficacy in dogs with osteoarthritis. In terms of the target, it's a very selective target, and that would lead you to expect that maybe the safety might be different. And indeed, I do think that the safety profile of grapiprant is pretty attractive. If you look at the target animal safety data, the drug was given at 15x each day for 9 months. So, if I took 4 ibuprofen this morning, what's 4 times 15? That's 60. So if I was on that target animal safety study, I'd be taking 60 ibuprofen every day for 9 months. So that just gives you an indication of the sort of, what 15x looks like. And what struck me about those safety data were that no dogs died. Young, healthy dogs, but usually when you do these target animal safety studies for veterinary or human drugs, you're looking at seeing, you expect to see some significant adverse events. So I do think the safety data looks good. That's been mirrored in the field trials. But now I want to come back to efficacy, because just recently, Steve Budsberg and his colleagues at University of Georgia published this study, comparison of 2 inhibitors of the prostanoid receptor, prostaglandin E2 receptor, and carprofen. That's the COX inhibiting nonsteroidal. So he looked at 2 PGE4 receptor blockers and a COX inhibitor. He used a urate crystal model of synovitis, and so that's where you take urate crystals, you kind of make up this little solution, you inject an amount into the joint, and it's inflammatory. I mean, it produces a pretty intense but relatively short-lasting inflammatory response. Short-lasting as in just a few days. And his outcome measure was using the force plate. So he injected the stifle. You can see here the stifle hitting the force plate. And the graph I'm going to show you is peak vertical force. And so this is peak vertical force as expressed as percent of body weight. You would expect them to start out here. You then inject the urate crystals. Now, in this study, he didn't include a non-treated control group, which I would have liked to have seen. And what you would expect is a dramatic reduction here in peak vertical force. So because of the intense urate crystal-induced synovitis, that joint's painful. And so the animals don't use it, a reduction in peak vertical force, which is the Z force, depending on how you orientate things. Usually the Z force going down is the ground reaction force pushing up. And so you can see here for carprofen, and carprofen was given just prior to the urate crystal, 2 hours prior to the urate crystal administration. Carprofen mitigated the expected decrease. This is L766, another EP4 receptor antagonist that again mitigated the expected decrease. Grapiprant probably mitigated some decrease, but we don't have that control group, but wasn't as good as carprofen, as a COX-inhibiting nonsteroidal. So now we have data which, I showed you earlier data in osteoarthritis, suggesting that grapiprant is as good as carprofen as an analgesic. Now we have data in the urate crystal model indicating that grapiprant is not as good an analgesic as carprofen. And then we have, this is one of these little kind of, pharmaceutical company TIFFs. So this study was set up, planned, done, performed by the makers of Previcox, who compared Previcox, which is a Firocoxibus selective COX-2 inhibitor, against Grapiprant. Similar model here. Let me just go back to this. So these are, and this may be important. This is 2 mils of a 17 milligram per mil solution in 25 to 30 kilogram hounds injected into the stifle. This study here is 10 milligrams in 1 mil injected into 10 kilogram beagle stifles. And I've worked with urate crystals. It's very difficult to predict the response you get, and the response varies from batch to batch of urate crystals that you make, and depending on the concentration and the volume and the size of the joint. But regardless, what you've got here, the treatments were administered 2 hours prior to urate crystal injection out here. And then you're looking at vertical force. They decided to present this for these beagles in kilograms vertical force. And you can see here at time 0, no difference between the groups, not much difference at 1.5 hours. And then at this sort of time here, where you start to expect that inflammatory response to kick in, you're looking at no limb use in the control and Grapiprant groups, and just a slight dip in the Firocoxib group. So suggesting that lameness was pretty severe in the Grapiprant control group, but that lameness was mitigated by Firocoxib in those dogs. Why the disconnect? Okay, so clinically you'd say Grapiprant is as effective as a COX-inhibiting non-steroidal. Based on the 2 studies I've just shown you, it's not as effective. I think it comes down to this model, outcome measure, therapeutic. So the urate crystal is a model with an outcome measure therapeutic. This is the target disease. The therapeutic's the same, Grapiprant. The outcome measure is a little bit different. In the model you're looking at limb use. In the target disease, you're looking at how the whole dog is responding and feeling. I think the biggest thing is the model. So naturally occurring osteoarthritis is a non-inflammatory degenerative arthropathy of synovial joints. There is some inflammation, but it's not like rheumatoid arthritis or immune-mediated or bacterial infective arthritis. It's a relatively non-inflammatory, and yet the model is an overt inflammatory model. And so I think we're going to have to get smarter about this. And just to reiterate this, so what you'll see going across this pressure mat here is a beagle after urate crystal injection. It's pretty, that's at the height. It's pretty severe. It's a dramatic inflammatory response. And this is a dog with osteoarthritis. Reasonably severe osteoarthritis of both elbows, more severe on one side. And so, that's just to illustrate, you've got this very intense inflammatory model. But where are things on the human side? Well, just recently, it's all been kind of quiet, difficult to know what's going on. Just recently, this Eli Lilly molecule had a publication on it looking at pharmacological profiles of this molecule, a selective EP4 receptor antagonist against celecoxib. And then more recently, this study came out. This is from, what's that group called? TCMR, Translational Comparative Medicine Research. It's a group Eli Lilly set up to run clinical trials in naturally occurring disease in pets in order to inform drug development on the human side. So this study was set up to look at different molecules in spontaneous or naturally occurring osteoarthritis in dogs in order to help decide which one to move on. At least that is what was communicated in the publication. And the molecules they looked at were up here, non-steroidal compared to microsomal prostaglandin synthase 1 inhibitor compared to an EP4 receptor antagonist. I'm not going to go through, it was a 2-week administration, 2-week trial, and gathered the outcome measures. They also continued to assess these animals for another 2 weeks. So what you can see here, and just focus on this one graph, this is the load. You saw that clinical metrology instrument owner questionnaire earlier. and you're looking at least squared means change from baseline. These are where the groups start out. A reduction in load scores is good. And what you can see, the keys a little bit down at the bottom, you can see placebo, that's the placebo effect, the caregiver placebo effect from owners. Then you see the greatest reduction with carprofen, the COX-inhibiting non-steroidal. LYA is the microsomal prostaglandin synthase inhibitor, and then slightly less reduction in the load is the EP4 receptor antagonist. So, again, maybe a suggestion of a differential effect. These are all in the ballpark of clinically effective. And so, clinically, you probably wouldn't be able to see much difference between them here. But a nice way of using naturally occurring disease to maybe look at relative efficacy or determine if there is efficacy. And I'm going to stop there and happy to take any questions. Questions now? Or?
Thank you. Yeah, I think we've probably got time for a couple of questions. Actually, there's one, if it's okay, that I'll start with, which came through on Slido. And probably for the vet community here, probably something that I think we get a lot of advice or requests for advice on, which is, can Grapiprant and steroids be administered at the same time, considering that this is a different type of non-steroidal, specifically a non-COX inhibiting?
Yeah, so if I put my clinical hat on, I have to say I don't know. I'm really interested for someone else to do it and see what happens. I mean, the reality is you're looking at the same pathway. So steroids are inhibiting it very high up. COX-inhibiting non-steroidal is a bit further down. Now the EP4 receptor antagonist is down at the bottom. So the question is, what is the cumulative effect of inhibiting this pathway at multiple levels? Pretty good data to indicate that steroids and COX-inhibiting non-steroidals are associated with a greater risk of adverse events. I would not be surprised if that wasn't true for Grapiprant as well.
Okay, interesting. And one other question actually has come through to ask: is there a role for EP4 receptor antagonists, do you think, in acute pain medicine, or are they destined to be chronic, long-standing pain exclusive?
That's a really interesting question, and I think prior to the urate crystal studies coming out, I did go back to the basic science literature and look at the acute pain models, the inflammatory models, and say, this molecule has efficacy in those models. So I would suggest, yes, it's going to be efficacious in acute pain setting. My clinical experience using it perioperatively is that I see no difference from any other non-steroidal. Then there's a little bit of a doubt, if you have a very, intensely inflammatory pain condition, is it going to be as good? And that's just because of the urate crystal data.
Yeah, I think that's probably something we're seeing clinically as well.
Okay.
Sorry, I think Kirsty was first.
Okay.
How much of an issue is does the field view the caregiver placebo effect?
Yes, so the caregiver placebo effect is a problem, just as in human medicine, the individual person placebo effect. The caregiver placebo effect is absolutely there. In dog studies, it's round about 20 to 30%. In cat studies, it could be 50 to 80%, which is mind-blowing, And so it's absolutely there. And it varies, and we've been able to show it varies if the medication is oral. In dogs, it's going to be 20 to 30%. If the medication involves a needle and is intra-articular, you're looking at 50%. And so that's why often in these trials we include other outcome measures to help understand, to help interpret the data if the caregiver placebo effect is high.
Doesn't that make you think you just can't use the caregiver effect? I mean, where the placebo effect is so enormous?
You're absolutely right, Kirsty. So your comments, you said that makes you think maybe you can't use the owners as measurement tools. And that's why this morning I tried to emphasize that these tools work in the blinded, placebo-controlled setting. They tell you whether the therapeutic is better than placebo. They are not an absolute measure, so it's a relative measure. And what you're looking to find is that the owners think that the medication, that the therapeutic was that much better than they thought the placebo was, to say, yes, there is a benefit. You're not convinced.
It's so subjective.
No, it is. It is absolutely subjective. But by the same token, I think, it's been mentioned a couple of times today, and Tony mentioned it, human patients are asked, hey, how's your pain? Now, if that's not subjective, and so, yes, I think we need to get smarter about how we do all of our research, right from, including the clinical aspects.
Thank you. And for
Just
Kathy.
sort of follow-up, which I think goes to some of the other questions. How good is gabapentin at actually reducing swelling? Because, if you get swelling where it can't move, like a joint, then of course it causes pain. So is that the difference, do you think, between the effect of carbapenem, which does reduce swelling dramatically? You almost see it disappear in front of your eyes, the swelling.
Right.
And the gabapentin.
Right. Yes, that's a very great question. And I think, some of the early basic science studies indicated that graviprant does reduce swelling, pore swelling and so on, using plethysmography, put the pore in a little test tube of water to measure volume. And so those data are there, but now you're looking at the urate crystal data, and absolutely you have to think, well, maybe in those very intense inflammatory conditions, there isn't enough of an anti-inflammatory effect. There may be an analgesic effect. Absolutely. And that's, again, that's, I think, why it works very well in canine osteoarthritis. It doesn't need to be have an intense anti-inflammatory effect. It's more an analgesic effect. Okay?
Thank you very much again to Duncan. We're going to have a coffee break now, and we'll see you all back in about 25 minutes.